All right, thanks very much. Thanks for inviting me to speak. So, for the last 2 years, there's been an outbreak of Ebola in West Africa, which, of course, I assume all of you would have heard of and would have seen pictures like this one. Just to give a bit of scope for what I will be talking about in the next half hour or so. The outbreak started, or we think the outbreak started in December 2013. That's when we have the first known case. An 18-month-old boy in a rural region of Guinea fell ill with diarrhea and vomiting and fever, died. Subsequently, members of his family died, and it was initially assumed to be cholera. A month later, Médecins Sans Frontières arrived in the area, started investigating. There were other cases kept occurring. It was presumed it was a cholera outbreak, and it wasn't until March, 13th of March, that the Ministry of Health declared that there was something serious going on, that there was a serious outbreak going on. So that was 2.5 to 3 months after the initial case. And so MSF sent more teams, and they started sending samples back to Europe. Initially, when the cases were investigated, they found traces of bacterial infection in blood. So that worked with the idea that it was something bacterial or maybe cholera. But in March, it began to be suspected that this could be viral, and samples were sent to Europe. And it was on the 23rd of March, 3 months after the initial case, that it was confirmed that this was indeed Ebola. And it was the first time Ebola had ever been seen, was in the region, in West Africa. There had been some cases in chimpanzees in Côte d'Ivoire in West Africa, but never in Guinea, so which may have contributed to the fact that it's not initially recognized as being Ebola. At the time when it was confirmed to be Ebola, by a lab confirmed to be Ebola, there had been 49 cases and 23 deaths, 49 recorded cases and 23 deaths. Of course, we don't know how much else there may have been going on, especially initially when it wasn't really clear what was going on, and there wasn't really a recognition that there was a serious outbreak. Médecins Sans Frontières, who really stand out as the organization who took this very seriously from the very beginning, as opposed to, say, the World Health Organization, for example, recognized that even though there weren't many cases seen at the time, and it seemed like a low trickle, it didn't seem like a big outbreak. And also, all the previous outbreaks of Ebola, and there had been 20-odd outbreaks of Ebola, all in Central Africa, had been very limited. The biggest one had been of about 250, 300 cases, most of them smaller. And the thing that was strikingly different about this outbreak that MSF recognized was there were cases coming from very different regions. So even though there weren't many cases reported, there was something strange about the fact that it was in so many different areas, suggesting that spread was already going on in a number of different areas. It took until the end of April that it was recognized as a serious outbreak by WHO, and an emergency was declared. And this is where we are today. So I talked earlier about December 2013. So these are confirmed Ebola cases. So obviously, initially here, there would have been probably a lot more going on, but these are the number of cases that were confirmed, lab confirmed. And you have the 3 countries here, so they're stacked on top of each other. So you have the total number is the height of the bar, and then the distribution between the 3 countries is the distribution of those colors. So you see this initial outbreak in Guinea, which then spilled over. And the period that I was talking about just now, that was March, April, so that was around here. And then it seemed like the number of cases reported was going down. It seemed to slow down here. And it looked just like any old Ebola outbreak in the past. And then something happened that hadn't been seen before. And there was an explosive outbreak, an explosive increase of cases around here in July and August, leading up to this peak here, so where you had a situation where this is weekly confirmed cases, so it got to a point where there were almost 1,000 cases, new cases of Ebola reported in that week. About 70% of Ebola patients infected with Ebola are known to die. So the total numbers, the official total numbers that we are left with now is that we have 28,000 cases, or over 28,000 cases, and over 11,000 deaths. Now, obviously, that's not 70%, 11,000 of 28,000, and that suggests that there's a large degree of underreporting, and the true number of both cases and deaths is probably higher. It also has had a knock-on effect on the health systems in West Africa. It had many healthcare workers died, and also routine health systems for, say, measles vaccination or treatment against malaria were similarly weakened. So what we see here really is only the tip of the iceberg of what has been an absolute catastrophe for the 3 affected countries, for Guinea, Liberia, and Sierra Leone. Now, I work in mathematical modeling of infectious diseases, and like many of the people who work in the field, when it became clear that this was a serious outbreak, we were keen to bring in our expertise and to bring in what we know about infectious diseases to see whether there's anything that we can help with. And in fact, it was around this time, in the beginning of August, that MSF got in touch with us, and they were running 6 Ebola treatment units at the time. So they were not normal hospitals. They had isolation units to very high standard. So the idea was really that cases could be isolated there. And I should say there's known to be 3 there's 3 ways in which you combat, or in which you concurrently combat Ebola. First one, and most important one, is isolation of cases. So you need to take infected people out of the community. Ebola is spread via bodily fluids, and the risk factors for containing Ebola are caring for a sick relative or friend, because you come in touch with them, and people are the most infected when they're about to die. So if you're caring for a person who's about to die, then this is something that makes you highly at risk from getting Ebola. And because of this, it's important to have sufficiently good health facilities where you can isolate patients, and you can make sure that people who come in contact and people who care for very sick Ebola patients have appropriate protection so that they don't get infected themselves. So care for people is a very important fact. And in fact, it's usually, especially in the beginning of outbreaks, in Ebola outbreaks, it's the same as happened in the past, that a lot of healthcare workers get infected. And that's because caring for someone is such a risk factor. The second way of combating Ebola outbreaks is to provide for safe burials. Corpses remain infectious and remain highly infectious after death. So it's a hemorrhagic fever, so it leads to a lot of bleeding. People, especially at the height of someone's infection and someone's illness, so at the time when people are about to die, and then also after death, people have incredibly high viral loads and are very infectious. And the third one is generally engagement with the community, and community behavior is generally seen as a third strand. So not just providing healthcare services, not just having this kind of biomedical intervention, but also just engaging with the communities and making sure there's good understanding of what's going on. Okay, so MSF contacted us. They were running some of these Ebola treatment units where they had isolation facilities, and they were running out of beds. And they wanted to know from us what we would expect, how we would expect this to go on. How many cases we would expect, say, a week from that point, or 2 weeks from that point, and what they would need, how much they would need to expand their hospital facilities by, or their treatment facilities by, to be able to cope with the expected demand. And it became clear very quickly that they were going to run out of beds. And in fact, in several places, MSF had to turn away people from treatment units because they were simply full. Okay, that's the backdrop for what I will talk about today. This is this is when we started working on the current Ebola outbreak. We started working on Ebola a little bit early already in July, but at that time we didn't have access to any data from West Africa, so we looked at some older data from earlier outbreaks in Central Africa to try and learn something about the underlying parameters of spread. But this is when we really started getting into Ebola and getting into forecasting. And I will speak a lot about forecasting today and something that obviously what I just talked about, how many beds will you need next in a week or two, that is a forecast. Okay, and we then throughout the rest of the epidemic we started. We provided forecasts of how we thought the epidemic would go on the basis of our mathematical models. So I'll talk about that in this talk. Okay, and what I would like to do is first of all give you a bit of background and talk about mathematical models for outbreaks in general, so that you get an idea for the kind of methods that we use to study outbreaks. I will then talk about what we need to do with these models to apply them to Ebola, to make them Ebola specific. And then I will get to the forecasting that we did and how we used these models to forecast while the outbreak was ongoing. So it was very much a moving target that we were trying to study. And so it's these three things really. So first background, and then then I'll tell you about modeling Ebola, and then about forecasting. Okay, so let's start with mathematical models. Now, someone very clever has once come up with an analogy between mathematical models and model railways. So you can think of a model in general, in very general terms, is usually a simplification of something more complex, and often of something that's in the real world, and you replace it with something that is not the real world, but a representation thereof. And you can use this to study perhaps something about your real world system or your real thing using this model. So perhaps you can learn something about trains from looking at this, and you can see that perhaps it has wheels and it rolls and so on and so forth, and you can demonstrate to a child how a train works. And an important aspect of models is that they have kind of varying levels of complexity. So whilst this is a very simple model of a train, this one is already on rails and goes under a bridge, so arguably is a more complex model of a train. And then this can go to the very sophisticated and some very detailed models of train. In fact, that's a useful analogy because that's similar for mathematical models. Now, according to the Oxford English Dictionary, a model is a simplified description, so as I just mentioned, it's especially a mathematical one of a system or process to assist calculations and predictions. So Oxford English Dictionary mentions both mathematics as something that bears a relation to models, and also that it can be used for predictions. And more precisely, when we talk about an infectious disease model, what we talk about is that we somehow describe an infectious disease process or infectious disease dynamics. So we describe how an infectious disease evolves over time in a population by using a set of rules or equations that describe how transmission in a population goes on, and therefore how the infectious disease behaves in a population. And there's two important things to note here. One is the model is never the real thing. So all of these things are not a train. All of these things you can't get on to get from A to B. A model is always a representation, and it's always a simplification. And it's not the aim to exactly reproduce the real world system. The key is, as I say in the last bit here, is to capture the key elements and leave out all the detail that can be that is unnecessary or that can be left out. And that brings me to the second point, which is that increasing complexity is not necessarily better, because by increasing the complexity of your model, you make it more difficult to understand individual processes, and it makes it more difficult to understand how one thing influences another. So again, you can think of the analogy with trains, and perhaps in this very complicated model, if all you want to study is how a train behaves when it goes around a bend, perhaps this is not a better model, but you get the analogy that here perhaps there's so much going on here. There's slopes, and then it goes up and down, and there's all these things going on with the tracks here. That perhaps you can't really. Perhaps sometimes it's better to use a simpler model if it correctly captures what you're trying to study. But that is, I think, the key intellectual effort in mathematical modeling of something like an infectious disease, is deciding on the right level of complexity, and that is there is no generally established rule for that, and it's this element here of capturing the key process and ignoring the unnecessary detail is difficult. Okay, so let's get more specifically. I'll just give you one example of a mathematical model for infectious diseases, so you get the gist of what we do. And what we use is we use so-called compartmental models. So you have a population in which there are n people. So think of Liberia, Sierra Leone, and Guinea. So there's 20 million people there, and you divide them into compartments according to their, depending on their status with respect to the infection. And so a simple compartmental model for an infection is called the SIR model. So this is about 100, 150 years old, and the idea there is that everyone in the population is either susceptible, so meaning they can contract the infection. Once contracting the infection, they become infected and infectious, so then they can infect others, and then after some time they recover and are no longer infectious and cannot be infected. So the idea here is that this is a model for an immunizing infection, so something that you recover from, or something that kills you. So from a mathematical viewpoint, as opposed to a public health viewpoint, whether you recover from a disease and are immune or whether you die doesn't make much of a difference. It means you're no longer infectious and you cannot infect anyone anymore. Okay, so we have S, we have the number of susceptibles, I, the number of infected, and R, the number of recovered or immune people. Okay, so we have these three categories, and we have the number of people that are in each category at any given time. So this is called the SIR model. Now, to describe dynamics, we somehow have to explain how people turn from being susceptible, how they become infected, and how they recover. And for this, we assume that these things happen with certain rates, or we say that these things happen with certain rates. So I've now given these two Greek letters here, lambda and gamma, and these are rates at which people become from susceptible infected and then recover. Lambda is called the force of infection, and what this is the probability per unit time, so per day or per week or per year, that a susceptible person gets infected. Okay, so one susceptible person, everybody who's susceptible has a probability, say a daily probability, and I'll make it daily in the rest of the talk to make it easier, but of course the timescale doesn't matter. But let's say it's my daily the probability on any given day that I become infected. Okay, and the way we write this in the SIR model is we say it's proportional to the number of infected. Okay, the more infected people there are, the more likely I am to become infected. And then everybody who's infected can infect me at a certain rate, which is the infection rate, or the probability per day of getting infected by a given infected individual. And this beta, this infection rate, is a constant. Okay? So again, my probability of if I'm a susceptible, my probability of getting infected in a given day is proportional to the number of infectious people around me, and then there's a certain rate which determines how infectious a disease is. Now, importantly here, we have used an assumption which is sometimes called random mixing or the law of mass action. And this is, if you think of this as I just suggested, as the population of these three affected West African countries of Guinea, Sierra Leone, and Liberia, this is saying that all the people who are currently infected have the same probability of infecting me. And I said earlier, I mentioned that people get infected perhaps caring for a sick relative or in a hospital or at a burial. Then clearly it's not that everybody who is infected has the same probability of infecting me. It's those that are close to me that have a greater probability of infecting me. And so this is an assumption which is almost certainly wrong, but potentially it could still give the right results, and it could still be a useful assumption. It's a very simple assumption that allows us to make calculation, but in critically assessing our models, we need to think about whether this is a correct assumption. And there are ways of getting around this assumption, but they usually involve more complicated models. And here we like to focus on simple models. So this is a simple model for how people get infected. Okay, and then we have this other rate here. We have this gamma. So this is called the recovery rate. So again, it's the probability per day or in a time unit of recovering from the infection and becoming immune. Again, this is a constant, so we're assuming that this is the same for everyone. And we can write this simply as 1 divided by how long people are infectious for. Okay, so it's 1 over the duration of infection. With this, we have fully specified the SIR model. And we can now think about how we write this down as equations. So how we can use equations to describe dynamically. And I said we're interested in how things change in the population, how this spreads. So we want to look at this over time. And so we look at a time t. So we call this S sub t is the number of people susceptible at a given time t, infected and recovered. And you may see that I replaced here in the force of infection. So this is now infection rate times number of infected at times t. And of course, this changes over time. So I said the more people are infected, the more likely everybody is to become infected. And the number of infected will change over time. And there's several ways of writing this down as equations. And I will use something which is called difference equations, which is, I think, quite an intuitive and simple way of thinking about this. So I simply ask, so given everything that I've said so far, what is the number of people susceptible and recovered at time t plus 1? Okay, so we want to go from time t, where we have S, I, and R, to one step further, say the next day. I want to know how many people are susceptible, infected, recovered on the next day. Okay, and to do that, well, if I do them, I look at them one by one. The number of susceptibles on the next day is simply, say the number of susceptibles tomorrow is simply the number of susceptibles today minus all the ones that become infected. And we said that everyone's probability of getting infected per day is this force of infection lambda. And then if I multiply that with the number of susceptibles, I get the total number of people that get infected in a day. And so my number of susceptibles tomorrow is however many are susceptible today minus the ones that become infected. The ones that become infected enter the I compartment. So if I look at the next equation for my I compartment, that's the number of people that are infected, plus all the ones that get infected. So these simply move from being susceptible to infected. So it's that arrow up here. This is this minus and this plus. However, some of the people who at any given time are infected will recover. So they recover at a rate gamma. And so this is, I subtract the number of people who recover. And the people who recover enter the recovered compartment, and this we have here. Okay, so with these three equations, I have fully described what happens to my process over time. If I give this some values at time 0, then I can simply look at what happens at time 1, at time 2, at time 3, and so on and so forth, and I can look at how this evolves over time. All right, and we said that lambda is nothing but this infection rate times the number of infected, so we can write it like this as well. Okay, so let's see what happens. Let's say we have a population of 1,000 people. These are our equations, and we start at time 0, and we start with 1 infected. Okay, so we seed our outbreak. We have our index case, December 2012 index case. So 1 infected. We have an infection rate and a recovery rate. See what happens. Okay, so you will see here in blue the number of susceptibles, in red the number of infected, and in green the number of recovered. Number of susceptibles initially is 1,000. I said it's a population of 1,000 people. In fact, it's 999 because I've made 1 person infected. And then here, because this is quite a thick line, you can't see the distinction between red and green. So this just looks green, but there's a red line below. So there's 0 recovered and 1 infected. Okay. I go 1 step forward, and I do this, and I see that over time, slowly, this changes. Okay, so what's happening here? Here, people become infected, and then after becoming infected, they start recovering. So this red line shows the number of people currently infected, so this is increasing. Number of susceptibles is decreasing rapidly here because they become infected and then recovered. And number of recovered people only increases. So this is everybody who has ever been infected is in the recovered curve, who has ever been infected and subsequently recovered. And if I continue this, so what happens here is that number of infected increases until it hits a peak. And then it starts decreasing. And this is because everybody eventually, or everybody who is infected eventually becomes recovered. So the number of susceptibles goes down and down and down and down and down. So the number of new infections that are generated becomes smaller and smaller at some point because there are not enough susceptibles anymore. So it's essentially when this term becomes smaller than this term because S is too small. Okay, so there's this peak, and then number of infected goes down, and the outbreak ends. And we say the SIR model in this sense is self-limiting. So you see an outbreak, but it's self-limiting. The infection limits its own capacity to spread, its own fuel, by burning through susceptibles. So we have this typical shape of increase, and then a peak, and then decrease. And interestingly, so the values we had here was beta was 1 and gamma was 0.5. Interestingly, not everybody gets infected. So there are people at the end who remain susceptible. And that's because the infection turns over here. Number of infected decreases because there are not enough susceptibles anymore. And then this happens at a rate which is rapid enough that it doesn't actually go through all the susceptibles. So some people remain susceptible. If we vary the parameters, so go back one step, so this was beta 1. So if we make the infection twice as infectious, so we double the infection rate, we get a much earlier and a much higher peak. And here you see nicely the distinction that you couldn't just see that people first are infected and then they recover. So the red is actually rises a bit earlier than the green curve. So everybody who becomes infected first becomes infected and then recovers. And so this and the previous one looks quite a lot like an outbreak. So like maybe like what we observe. And then so if I increase the recovery rate, so from here to here increase the recovery rate, so then this again gives a lower outbreak here. So and there can also be situations where there's no outbreak at all. Okay, and that's because the recovery rate is, or the infectious rate is too small with respect to the recovery rate. You can't have an outbreak. Key message here is we see this. We can see this kind of behavior of an exponential increase, and then a peak, and then a decrease, which is characteristic of outbreaks. So it's a model for outbreaks. And the other one is that the timing and the height of the peak and the total number of people infected depends on these two parameters, on beta and gamma. Now, if we go back to this picture and where we are in August, well, we can simply use this model, and we saw we had this increase in I, so this increase in the number of infected. Well, we simply try to find the beta and the gamma that describe this curve. If I go back, so I try to find the beta and the gamma so that this increase, I see I can vary it by varying the beta. I find the values that match the observed curve of cases, and then if I imagine in my outbreak, maybe I'm somewhere here in the Ebola outbreak in August, well, then I can forecast by just running my model to the end. Okay, so this is what one could do here. Use the SIR model, match this exponential increase here, and then just let it run. Now that's exactly what at around this time the CDC did, the Center for Disease Control in the US. And I will get back to that. I will just, before I get back to that, talk briefly about how we need to modify this model to make it a model of Ebola. Okay. Now, to illustrate this, I thought it's useful to look at this story about one individual case that encompasses a lot of the things that are particular about Ebola, and I've mentioned some of them before. So this is about a 70-year-old male resident of Kuremali village in Guinea, the Sigiri prefecture of Guinea, who had onset of symptoms from an undiagnosed disease on the 17th of October. On the 18th of October, he was admitted to a private clinic in the mining town of Sigiri. On the 25th of October, a week later, he traveled by car together with 4 family members to seek treatment at another clinic, at the Pasteur Clinic in Bamako. He was there treated from 25th of October until his death from kidney failure on the 27th of October. And this was an influential person, quite an important person in that village. He was a religious leader. So his body was transported to a mosque in Bamako for a ritual washing ceremony, and the body was then returned to the native village of Kuremali for formal funeral and burial ceremonies. So the key things here are, first of all, okay, so there's some onset of symptoms, but there's a period that passes between infection and onset of symptoms, the so-called incubation period. And we know this can last up to 21 days. So upon infection, first of all, one shows no symptoms, and one is perfectly capable of traveling. Obviously, here this person, even though he had symptoms, he was ill, he was still able to travel to another place, and was then admitted to a hospital, to the Pasteur clinic. And the other important thing, and I mentioned this earlier, is this transmission after death. And there was a big burial ceremony, and it is assumed that several people were infected by this particular person by attending the funeral and touching the dead body. Okay. Neither this incubation period that I've just mentioned, nor the infectiousness after death is captured in that SIR model that I just described. So how do we need to adapt this model? So first of all, looking at the incubation period. So what we do simply is we insert another compartment here between susceptible and infected, which is often called the E compartment. Well, we can't call it I again. We've already used that for incubating, but then E is for exposed. So upon infection, people enter the E compartment where they are not infectious. So the number of infected, or the force of infection still depends on this I, but does not depend on E. But then everybody, after a while in this E compartment, enters the I compartment and becomes infectious. And the second aspect, the infection at funerals, well, in some ways, this is simply like saying people have a slightly longer duration of infectiousness. So it's longer than the time from infection to recovery or infection to death. It's a bit longer for those who die. They have a bit of a longer period of duration of infectiousness. So we said that the duration of infectiousness, we said that gamma is 1/d, so this simply amounts to a change of gamma. Okay, and then we can do what I just said. So we can match this and this. We can match the outbreak data with these observed dynamics. And this is what was done in a very influential paper that came out of the US Centers for Disease Control. And what they did, and they really did exactly that, they put together a model in Excel, which was exactly like that model that I described on the previous slide, so exactly like what I showed earlier with the modifications on the previous slide. The only other thing they had is they also accounted for underreporting. So they produced two curves here. The blue curve is the so-called uncorrected curve, where they just use the data as they are and make a prognosis, and they use data up to the 28th of August, so around here, or maybe more like here, and then they also have this corrected curve, which is where they assume that there's underreporting by a factor 2.5. So only 1 in 2.5 cases gets reported, and then the number of true cases is obviously higher because we see only the tip of the iceberg. Okay, and then, so importantly, so they did this, they ran the model until the end of the year and then a bit further. So again, this is the situation, they fitted their model to the situation here, and so to around here, where there were around 5,000 to 10,000 cumulative cases. This is cumulative cases shown here, so this is total number of cases by that point. This is in thousands, and what they find is that by the end of the year, or by 20th of January, there could be, or what they estimated is that there would be 550,000 cases, or there will have been 550,000 cases of Ebola, or 1.4 million when corrected for underreporting. And this estimate received wide news coverage. So I just picked one of the many items of news coverage. This was really heavily reported, saying up to 1.4 million people could be infected with Ebola by January. And what really happened is this. So this is the same graph I showed before, just on different scales. So what before looked like this kind of dramatic increase is now down here, but it's the same graph. So well, I showed you the graph until August. This is until the 1st of January, which is when they stopped their prediction. So what you saw before on the slide was up to here. So it's again the 3 countries, if you can discern the colors here. But importantly, the number of cases which there really were by the 1st of January were around 10,000 and not 550,000 or 1.4 million. So you could argue that this was a gross overestimate and obviously something seriously wrong with the model. Okay, and there was a big article about this in Nature, important scientific publication, claiming that this raises questions over the usefulness of models. Okay. There's two important things here that need to be mentioned. One is that while it was widely reported that there would be 550,000 cases, 550,000 or 1.4 million cases, according to whichever estimate one uses, the start of the sentence says without additional interventions or changes in community behavior, for example, notable reduction in unsafe burial practices, the model also estimates and so on and so forth. And in fact, they even provided a curve for what they thought would happen if appropriate changes in funeral practices and bed provisions would be, and isolation would be supplied. So they just looked at what if isolation increased so that 70% of cases would be isolated, and they end up with something which looks more like the true number. So this is 7,500 and 20-odd thousand for the corrected number. So this is much more like the true number. And of course, what happened is that partly as a response to the paper, there was a massive international intervention, and there was a massive CDC itself sent an enormous number of people there, more than they had ever sent ever before, and by a degree of magnitude. So it had thousands of people in West Africa, and not just the CDC, also China, Cuba, the UK sent loads of people to Sierra Leone. So there was a big intervention, and there were clearly also changes in community behavior in that there was a recognition in affected communities that this was serious, that something had to be done, and that something could be done about this by changing funeral practices and by bringing people into the hospital. Okay, so and then in fact, there was a very recent, it came out a few weeks ago, there was Tom Frieden, the director of CDC, was headed an article by CDC where they looked back now that the outbreak is nearly over. And in fact, it should be said, I forgot to mention earlier, the last 2 weeks were the first weeks since December 2013 that there have been no cases of Ebola. Okay, so this very recently, it now looks like this outbreak might be over. Of course, I should say there has been no case of Ebola in West Africa, and it looked like we had a case of Ebola in the UK with Pauline Cafferty, although today it has now been confirmed that she had viral meningitis that was exacerbated by the Ebola in her central nervous system. She didn't fall ill with Ebola again. But anyway, so in West Africa for the last 2 weeks there has not been a case of Ebola, and this is the first time in almost 2 years. Okay, looking back, this is an article about the whole response and everything they did and trying to critically assess what they did. But interestingly, this article mentions that the CDC model was key to increasing the speed and scale of the US and global response. And they mentioned 4 key findings from that model that I just showed you. One is that cases were increasing exponentially and response needed was massive and urgent. The second one, that there was a severe penalty for delay, for coming in later and making changes later. That there would be a tipping point and that the epidemic would decline if enough Ebola patients, and that what they estimate they came up with was 70% were isolated effectively, and that then after the tipping point, transmission would decline rapidly. Now, all of these insights you can get from a simple SIR model, really, and but I think it's interesting that these relatively simple insights, using a model in which I talked before about mass action, in which it was assumed that you have the same probability of infection from every infected person across the region, that these retrospectively were seen as something useful and something that sped up the response. Of course, in some way, this is an infectious disease model as conundrum, that if our model predicts that something will be very bad, then this often serves to stimulate a response to try and make it not so bad. And in those cases, then, with hindsight, the predictions were wrong, but perhaps they were correct in the hypothetical scenario in which there had not been an intervention. We'll never know. And that brings me to my last point, which is what we actually did. And so we did something different. And in fact, what we were trying to do is do something which would be ongoing during the epidemic and track the epidemic as it went along and be updated week by week. So we started off, I mentioned earlier, by this request from MSF of providing forecasts for how many beds they would need. But this then turned into something whereby we would provide forecasts week by week. And to do that, we did something different, and I'll talk to you about what we did. So this is the same graph that I just showed you, except that now the three countries are separated. And what you see is that actually the dynamics were quite different in the three countries. So the scales here are different. So this is, now we're looking at weekly cases, so not cumulative cases, so 200 cases per week, 500 cases per week, 600 cases per week in Guinea, Liberia, and Sierra Leone. So in Guinea, there was this the initial outbreak was in Guinea, and then there looked like was another outbreak, and then this kind of very long, ongoing tail of the outbreak. Whereas in Liberia, note the number here is higher than that one. There was a very violent outbreak, which, however, stopped relatively quickly, compared to Guinea at least. And then in Sierra Leone, the peak a bit later, and then again, slightly longer tail, so perhaps somewhere in between those two scenarios. And then, if you look into more detail, if you look at different districts of Sierra Leone, so the previous graph was the sum of all these districts, you realize that if you try to make forecasts on a regional level, and this is what we were trying to do, so when it came to forecasting what was happening around the hospital, we were trying to forecast how many cases there were in that region. And when it comes to that, if you put yourself into a situation, say somewhere here, you try to forecast how many cases there would be a week in advance. This is very difficult because the thing goes up and down quite a lot. There's a lot of stochastic variation. There's also things where it looks like an outbreak is gone, maybe it comes back, and the dynamics look very different across the region. And the reason this is the case is, of course, because on this small scale, a lot of things are going on. And in fact, there's a lot of things going on that we, at the time, couldn't quantify and couldn't put into our model. So things like how much transmission there was in the community compared to how much there was in a hospital and infection of healthcare workers. How much transmission there was in funerals. And then, importantly, whether there were any changes in behavior or changes in reporting. Obviously, what I showed on the previous graph are only the reported cases. They might not necessarily coincide with the true cases. They almost certainly don't coincide with the number of true cases. But the degree to which they coincide with the true cases may also change over time and depend on reporting behavior or also public health efforts. There was a number of interventions put in place, and I mentioned earlier that the different international players that put in intervention, also local interventions. There was a number of things that happened, and there was a number of other things that could have happened later. At the time, we didn't know whether transmission was perhaps seasonal, and most Ebola outbreaks in the past have been in the summer, so we didn't know whether any waning, this decline in the winter was perhaps some seasonal effect where they would come back in March, and so on and so forth. And this here perhaps illustrates some of these aspects. So this is the reconstructed transmission chain from the very first case of, from the index case, so this one here. So this was the young child who fell ill, who we think is the index case, and that went to family members, to a nurse, to another village, and another village, to a hospital here. A healthcare worker got infected, a doctor in another hospital, doctor's brothers, and so on and so forth. So it's all these different things happening at the same time, and on a small scale, this becomes very difficult to quantify. Because of these uncertainties, we decided to model this in the following way. We use this SIR model that I described earlier. So it's a model that's modified for Ebola. So we have this incubated state, and also our recovery rate takes into account that people stay infectious after death. And there are things that, with all these unknown that I just mentioned, there are things that we know, and they're encapsulated in this simple model. So we know, for example, the average incubation period, the average infectious period, so how long people stay infectious for, and the case fatality rate. So combining the two, we can come up with an overall infectious period that takes into account that people who die may stay infectious for a bit longer. There's just one difference to the SIR model that I showed earlier, and it's that there's now a T here. So what we do is we allow the transmission rate to vary over time, and we try to estimate how this varies over time. And we assume that this encapsulates all the things that I mentioned earlier, all the changes that could happen are encapsulated in a time-varying changing transmission rate. And the way we allow this to vary is because we didn't know how it might have varied, we try to come up with a formulation that is as flexible as possible. And something that is very flexible is to just let it do a random walk. So this is something that's often used in finance. So we use the log transform to make sure that it stays positive. But then we have this stochastic process here. So this is just a random walk or Brownian motion. And then there's some kind of volatility which governs how much the transmission rate can fluctuate over time. And then we estimate by looking at which trajectories of this random walk in the transmission rate reproduce the trajectories of observed cases. We try to reproduce how this transmission rate changed, and then we use that to predict what will happen in the future, or to forecast what will happen in the future. And I'll give you an example here. So this is from one area in Sierra Leone, from western area. We have these number of cases here reported. This is in subsequent weeks, so it's 6 weeks of data here. There's obviously an increase. And what we do is we fit the transmission, we have this trajectory of the transmission rate, or we have something that's slightly different from transmission rate, but it's a scale transmission rate with the convenient property that whether it's above or below 1 tells us whether the outbreak is increasing or decreasing. Okay, so at times where the outbreak is increasing, this will be above 1. Where it's decreasing, it'll be a bit below 1. And if it's below 1, we know that we're in a situation of control, where the outbreak is no longer increasing. Okay, and so this is fitting to these 6 weeks. So we get this trajectory, and then what we do is we assume that. So this was looking back from this. This is what we did in mid-September. We assume that the transmission rate stays the same as it is at the last data point. Okay, and from this we have a projection for the weekly reported cases. Okay, and then we do this in some kind of statistic way. So we have confidence intervals around this. So this is what I showed before, is our median prediction and our median estimated transmission rates. And then in the following graphs, you will always have these two lines here, which is the interquartile range, so 50% confidence interval or credible interval. And then the outermost shading, which you can hardly see here, is our 95% credible interval. What becomes very obvious here is that looking at these 6 data points in mid-September, it becomes very difficult to predict January. In January, anything could happen. Okay, so anything between, obviously it's cut off here, anything between 0 and 3,000 weekly reported cases and a lot more. Something that CDC chose not to do was provide a range around their estimate, and this was justified by saying that in politics, people want a number, not a good estimate or something that could potentially be justified later. So, and in fact, we had a lot of interaction with policymakers here or the government here, and this is not to be dismissed, and it's the fact that in politics people prefer to have a number because this is something they can base a decision on, and potentially you can't make a decision based on something that is a range between 0 and 3,000. So this is not to be dismissed, but it's not very scientific to just give a number. Okay, so anyway, so what really happened with this? So as you can see, of course, we were right, because it's within our confidence interval. And okay, but more to the point, what I'll show you here is our 1 week predictions. Okay, so as I mentioned here, so this, just going back one slide, becomes very difficult to predict far into the future. So, and perhaps these first couple of data points are quite close to the median here, but then something happened that was very different from what was happening mid-September, and these changes are not captured in what we predict here because we assume that everything stays the same. But we can update these forecasts every week, and that's what we did. So this was, I start now with 3 data points. This is our prediction, and then this is what happens. Okay, so again, this is our median interquartile range, so we were a bit off here, but okay, so then make a correction. Next week, this is our forecast. This is what really happened. Okay, forecast, this is what really happened. Forecast, this is what really happened. And we did this week by week. Okay, and here, this data point is far outside what we predicted. It looked like it was increasing, but it wasn't. But there was a 3-day shutdown in Sierra Leone in September, and this or around this data point, where there was a so-called case-finding mission where people went from house to house and tried to find unreported cases of Ebola. So perhaps this increase could be explained by that case-finding mission as opposed to a genuine change in transmission. But I told you earlier about all the unknowns, and I had this list of unknowns, and we subsume all of that, including changes in reporting, in the transmission rate. So this is obviously a point where our model fails. Okay, but then we can correct for that. We come up with a new prediction, correct, predict, and so on and so forth. And then this happened. Okay, so widely outside our prediction and a massive decrease in the number of cases, which again, we don't know why this happened. Okay, keep on doing this. And here again, similar thing happened. Potentially the impact of the interventions or behavioral changes or whatever happened around that time in Western area. At the time, now we spend a lot of time trying to look back and trying to understand these curves, but at the time, we were trying to do things as up-to-date as possible, and we didn't have sufficient information to tell or to inform our models with anything that happened on the ground there. Okay, and we go on, and you see, I said earlier that once you're below 1 here, the epidemic is decreasing, so that's what you see is happening here. So it's decreasing over time, and our transmission rate is now in a subcritical regime here where there's decline, and we end up somewhere here. Okay, so this is I stopped this in February, and I should mention that I said earlier that in the SIR model you have a peak, or you have an outbreak, a peak, and then it declines, and we have sort of the same here. And I said in the SIR model that happens because the infection runs out of susceptibles. This didn't come anywhere close to running out of susceptibles. So with an overall so-called attack rate, or the overall number of people that were infected, I mentioned earlier that the number of reported cases is something like 28,000, and this is in a region of 20 million people. So this would be around 1 in 1,000 people were reported to have had Ebola. It was probably more, but it didn't come anywhere close to infecting the whole population. So it was not depletion of susceptibles. It was something else that turned the epidemic around. Of course, the suggestion is that it's the enormous international and local, regional as well intervention and the public health measures that were put in place, the extra hospitals that were built, and we're now spending a lot of time trying to assess what it was, whether it was changes in behavior or changes in bed provision, provision of isolation, changes in funeral practices that caused this decline. But this is now looking back. At the time, we didn't have any of this information to inform our model, so this is what we did. And this is the overall curve. So these are the individual confidence intervals, and you see that those were those outliers. So here's an outlier, and here's an outlier, and this is the overall curve. And we're now also another bit of work that we're trying to do now is trying to assess how good this forecast was, and whether this is anything better to just drawing a straight line between the last 2 points. And this is something that we're investigating now, and obviously that we'll be keen to know for future outbreaks. And there is a valid standpoint whereby in a situation where you don't know a lot of what's really going on, and all you have is the number of cases, and there is so much going on as there was going on here, and so many changes, perhaps it's futile to forecast. But this was our attempt, and we're now trying to assess this. And just as a last point to mention, so we published these, so we had weekly, this is our website, and then we had these weekly reports, including the forecast. So there was some data summary and some modeling and projections, and part of it was just presenting the data in a somewhat accessible format. So this is just from, I think it's from one country, and then confirmed, probable, and suspect cases. And in fact, we were quite curious in whether people were actually interested in that kind of stuff that we did. And in a lot of cases they were, and there was generally a high level of interest and a lot of requests to us. And one aspect that surprised me, but perhaps with hindsight is not so surprising, is that a lot of the people who went out to West Africa to help, or Western or Europeans or Americans or people who went to West Africa to help, actually had no clue what was going on in the epidemic, or even local health workers. didn't really know what was the largest situation in their area. All they saw was something like 10, 20 cases of Ebola arriving in their hospital every week and them running out of hospital beds. But they didn't know what that meant in the context of the wider epidemic. And so I think in some ways there was an even greater recognition for just presenting the data than for doing the fits and the forecasts. But recently, I think the forecast became from interesting to being useful, and that's when it came to the vaccine trials. So we've been working with all the vaccine trials that are now going on in West Africa for Ebola vaccine trials. And this is because it's a bit uncharted territory to do a vaccine trial whilst there's an epidemic ongoing, because you need to work out your vaccine efficacy. You need to know how many cases you would expect, and then how many cases you see in your control group where you don't give the vaccine. And if this is changing over time, then you need to somehow make some prediction of how many cases you would expect, and this is something that we've been helping with using these things. Okay, so just to briefly refresh your memory with all the things that I've talked about. So I presented to you the SIR model as a simple compartmental model for how an infectious disease spreads. I showed you how one could modify it to use it to Ebola, and then how the CDC used exactly that to come up with a forecast for Ebola at the end of August, a forecast for what would happen until the end of the year, and a bit of discussion of whether that was a good or a bad thing, or a good or a bad forecast. I then talked about that was the large-scale forecast, and I talked about our much more detailed small-scale forecast and how we did that and trying to track the epidemic over time. And so that leaves me to thank, first of all, everyone who's contributed and my funders, and then even more importantly, you for listening to me. And if you're interested in the stuff that we're doing, then this is our website.